Namaskar, dear viewers. Welcome to today's session of Young India Intensivist Critical Care webinars. And today we are indeed honored to have Dr. Marc Leone. Sir is a professor and chair of anesthesiology and intensive care medicine at Marseille University, Marseille, France. He has more than 250 publications, including major journals, book chapters, and guidelines. And he has edited 4 books in critical care and related fields. So, very much grateful to you, sir, for sparing your time and taking this very important topic on sepsis and that to clinical assessment, which I think is fundamental and which will be of a great asset to all the students and young intensivists. Thank you very much, sir. I hand it over to you, please.
Thank you for inviting me. Thank you to the organizers and thank you for you, Dr. Bensel, for this kind invitation. It's not very fashion topic as can be machine learning or artificial intelligence, but I think that's really critical point in our education, and I think that. Despite the development of artificial intelligence, machine learning, or the informatics, we will need again and again clinical assessment, and I will focus on patients with sepsis. So my disclosures, no relationship with this presentation. And the agenda of our presentation today, we will start with a kind of contextualization of the clinical examination. Next, we will focus on diagnosis, and diagnosis is very important in the process we can conduct in front of a patient with sepsis. We will stress on the cause of sepsis. If you don't have a cause, if you don't have a good etiology for sepsis, that's very difficult to treat adequately your patient. Clinical examination makes it possible to assess the severity of the disease, and it is also a critical point. And at the end, we will I have few slides for some clinical improvement we can develop today and in the next future. So let's start with context. So what is context? The context is when you have a patient in front of you in the bed in the ICU. You need to make a clinical assessment. What does mean clinical assessment for me is to collect the medical history of the patient, and it's very important. The medical history is our way of life also is important. The risk factors for sepsis, the risk factors for BMR, the risk factors for everything. Next, you have the step of the clinical examination by itself at the bedside. And I think that those last years, we lost a lot in terms of clinical examinations, spending time at the bedside, just being with the patient, not with a screen, not with a computer, but with the patient at the bedside, touching him, being in contact with him. And what I ask to my student is not to give words and words, lines and lines, long discussion about the patient. What I want to my student is to have a synthesis, which is important for this patient in terms of management, because we are all in rush all the time. We don't have time to lose, and we need something I call synthesis. We need to have a good view of the patient in few words, only in few words. What is important for this is to avoid what I call tunneling. For example, you receive a patient from pre-hospital or from the emergency department, you are in the ICU, and the previous doctors told you this patient is bleeding, and so you are not considering other diagnosis than bleeding, and that's a tunneling effect. And I think that's really important to avoid this. We should have an open mind when we have a patient, and don't forget the recommendation of the diagnosis proposed by the previous doctors. But try to keep an open mind to consider every diagnosis possible. Don't lose time because we are also all in a rush and we need to save time, and time is life in sepsis. If you lost 3 hours to give the antibiotics, there is a loss of chance for your patients. Don't be lost in details. There is a lot of details which are not useful, and my medical students are all the time obsessed by these details, uh, detailing such things that we don't need, and being really focused on which is important is really difficult, in fact, but that's important, and not be a simple bureaucrat that repeat which has been told previously without any improvement, or without any reasoning. You should be very responsible for each word you are going to use, and that's really important. So, in front of a patient suspected with sepsis, you have to find some very common symptoms, some general symptoms like fever, chills, fatigue, and some localized symptoms like swelling somewhere, pain, organ dysfunction, redness. And you should look at your patient very carefully for each of these signs. Your examination should be fast. Don't lose time. Each minute may count for the patient's survival. Look at the patient with septic shock. If you lost 1 hour to be very exhaustive in your examination, the patient is going to die with a good diagnosis, perhaps, but not with good treatment. So be fast. We don't have a lot of time. Be adapted to the patient and to the symptoms. Don't don't lose too much time with details which are not important in view of your management. With, you don't care with some antibodies, some details that you don't need for the treatment the patient you have in front of you. Be systematic. I like to go from head to toes, but you can do differently, but be systematic and use all the time the same process. I like, once again, to start with head and to go to toes, but you can go from an organ to another organ if you want, and try to be discriminant in your approach. So don't be too much uh, in non very specific or precise examination. Be discriminant. You have to find the cause. You have to find the source of infection. You have to find something which is useful, not all the time in mid. We don't know very really well. So you can you can perform a 45 minute neurological examination, but in patients with sepsis, that doesn't make sense. So be efficient. Don't overplay with the clinical examination. notably in a patient with septic shock or with sepsis, because time is life. For neurological examination, for instance, you can have 5 minutes, because if you need details, you can have a CT scan, and it's very fast. So try to be systematic. Use to do a clinical examination, including neurological examination, but don't lose time. Don't lose more than 5 minutes for that. Once again, 3 words, and that's my recommendation. My first recommendation: be systematic, be efficient, be fast. In a patient with sepsis or septic shock, you need to decide if you gave antibiotics within the first hour. So within the first hour, you should diagnose the sepsis, collect some blood, collect some samples, and give the antibiotics. You don't have time to lose, and you should be very systematic in your approach. Now there is a lot of data on electronic medical records, and takes times. Really, that takes times to explore the electronic medical records, especially in patients with multiple hospitalizations, and that's more and more difficult to have a very quick assessment of the patient. And I think that in the today already, but in the next future for a young fellow, the artificial intelligence and machine learning can bring a lot on that, because the human brain can process 4 or 5 variables, and in the EMR you have, in the electronic medical record, you have lot of information, but sometimes it's really difficult to find the discriminant information. And I think that for this, the artificial intelligence, machine learning, and everything in this dimension can help in the future to find the relevant information, the discriminant information, and to avoid details which are not useful. So that's very important. So as you can see, the artificial intelligence and machine learning should be included in the process of clinical examination. Is not in competition with clinical examination. That should be part of the clinical examination to save time and to be more comfortable with the high number of information we can have in a medical record. So when you have contextualized and you suspect the sepsis, you need to confirm the diagnosis, and that's a very important step. The diagnosis of sepsis from a side should remain uh, at this time. Perhaps that's going to change, but should remain something very clinical that you assess at the bedside. That's not something you can use a lot of tools for discriminating. You need to be at the bedside, and you need to be fast, and to manualize. There is no really good tool to help with this. So I would say I I I discriminate a patient with sepsis. I diagnose a patient with sepsis. First, there is a slurred speech or confusion. Confusion is really something you should think about. Sepsis, if you have a patient with confusion all the time. Extreme shivering, muscle pain should evoke sepsis. Passing no urine in a day. If you ask to the patient, you ask to the nurse, you ask to the husband or wife or son, uh, did the patient piss today? If he doesn't pass urine in a day. That's a good sign of acute renal failure, in fact, and sepsis. Severe breathlessness should be considered as a sign of sepsis. Even if the source is not the lung, there is a lot of patients with dyspnea, with sepsis, which is characteristics from patient in sepsis is it feels like you're going to die, and the patient tell you I'm going to die. That's typically different in patients with pulmonary embolism, for example. They are fine and they are dying. The patient with sepsis is going to tell you, oh, I'm going to die, and that's true if you don't intervene very quickly. But they feel that, and that's important to have that in mind. And the skin, you should look at the skin, and the skin mottled or discolored is very good sign of sepsis. We try, and a lot of experts try to construct to make a scoring system to diagnose sepsis, and there was a source criteria, and later there's been the quick SOFA. You don't, I assume you all know the quick SOFA system scoring. The quick SOFA is hypotension, confusion, altered mental status, and tachypnea. In a patient with two of the three features, hypotension, confusion, tachypnea, there is a risk of sepsis, and that's the rationale for quick SOFA. Uh, this score has been debated. Probably that works pretty well in the emergency department, less in the ward or in the ICU, where source criteria are being equal or even better. And quick SOFA has some limitation, notably in the elderly patient in whom it's difficult to communicate, and for instance, in patients with brain injury. So anyway, scores may be useful, and pretty much they are useful. But for me, score are not really important. I prefer wording, and I think that words are more useful than scores. And I like my student, my resident, describe the patient as he or she is better than using scoring system, which are difficult to apply and which not systematically reflect the patient's status. My second recommendation, and I stress on that, that's very important. That's a very, very important recommendation for me. That in terms of diagnosis, be unicist. I dislike when my resident tell me, oh, this patient has a sepsis and a pulmonary embolism and a cardiac failure. No. In French, I don't know the translation, but in French, we say that one cannot have scabies and cholera. So you should have one diagnosis. If you have sepsis, it's sepsis. If you have bleeding, it's bleeding. That's true that sometimes in 5% of cases or in 10% of cases, you can have a septic patient bleeding or a septic patient with pulmonary embolism. But that's very important to keep one diagnosis at the onset of hospitalization at ICU admission. One diagnosis. Be unicist. Try to keep one diagnosis. You can not have a sepsis, pulmonary embolism, and the sepsis source can be the lung, but also the abdomen and also the renal. No, try to be unicist all the time. And being unicist, you are going to exclude differential diagnosis like bleeding, and in these patients, sometimes hypotension may reflect only bleeding, severe or less severe bleeding, but hypotension, which is symptoms of sepsis, can also be a sign of bleeding. So be very careful with that. Pulmonary embolism can be a challenging differential diagnosis. That's all the time quite difficult. If you think that your patient may have a pulmonary embolism, you should use ultrasound, and you should go to the CT scan to exclude this diagnosis. Yeah, that's very important. If you put the word pulmonary embolism, this diagnosis should be excluded by a CT scan if you are not sure. And there is a problem of cardiac failure. Cardiac failure may be a diagnosis, an acute cardiac failure that can be a diagnosis in lot of patients. But this can be included in the picture of septic shock. So you should be very careful with this, and there is no patient with septic shock and acute cardiac failure. You should discriminate if the acute cardiac failure is part of the septic shock, or it is two pictures in the same time, which can open, but once again, try to be unicist, and I prefer a cardiac failure due to septic shock. So it's important to take a little time. Once again, uh, don't lost too many time, but you have to exclude other diagnosis of shock, of hypotension. That's very important. So we are continuing with our agenda, and which is really critical is to identify the cause of sepsis. I push very strongly my resident to find the cause of sepsis, and not to say, oh, he has a sepsis, the patient has a sepsis, but we don't know really what is the cause. Or perhaps it's the lung, perhaps it's the abdomen, perhaps it's the urine. No, you should have a cause. If you have a sepsis, you are a source of sepsis, and you have to identify the source of sepsis because the bacteria are somewhere, and you should find this source, this focus of infection. So what are the main source of infection? Probably in wards, urinary tract is an important source of infection. Lungs, in ICU patient, lung is the first source of infection, but be careful because lung infection is really a challenging, a tricky diagnosis to do, and for me that's one of the most difficult diagnoses I have to do in my clinical practice. So lung infection is probably a little bit overstated, overdiagnosed, and be careful with lung infection. Every patient in the hospital, every patient with shock is entitled as lung infection. Be careful, notably in surgical patient after surgery. After surgery, the source of infection by definition, except if you can exclude this very formally, but the source of infection is a surgical site, and nothing else. And if the surgical site is abdomen, is the source of infection is abdomen, except if you are sure that it is not abdomen. And the other source of infection is catheter. You should be very careful with line, and you should inspect every lines and you should expect every surgical site also. It is very important, and I like this review from my friend Jan Devel, explaining how to manage the source control in patients with sepsis and septic shock. Try to be naive first. So try to be naive and look at the patient systematically from the head to the toes. You should look at the head, look at the neck, look at the earth, look at the abdomen, skin and soft tissue, the central nervous system, the device associated infection, the chest, and all the genitourinary tract. If you don't find, try to think out of the box, but first be very systematic on the common cause of infection. We recently published this paper, which is in line now. It's a national database on patients with cancer and septic shock. That's a nation-based cohort. There is around 80,000 patients. And what we find that the patient with early ICU admission, but that's another point, but early source control and early pathogen identification is strongly associated with improved outcomes, so decreased mortality, in fact, in this study. That's very important to know which is the source, which is the pathogen. If you don't know the source and the pathogen, you cannot give the good treatment and the adequate and efficient treatment. So know the source, know the pathogen. That's very important. We all the time in terms of source control, we as intensivists, we tend all the time to focus on surgeons and say, oh, the surgeon should manage this patient quickly, should be faster. But let's look at our patients, and one of important thing is to search and to remove all peripheral lines in patients with sepsis, all central lines, or implantable chambers. And even if it's 2 a.m. in the night, if my patient is in septic shock and there is no another focus of infection, another source of infection, I have to remove an implantable chamber. That's very important. And basically, if I don't impair the outcome of my patient, I should do that in the first 2, 3, 4 hours max. So rule out the cause. That's very important. And that was the meaning of this paper published by Mathieu Legrand and Elia Zoulet long time ago now. But that they show that in neutropenic patients with severe sepsis or septic shock, removing the willing catheter was really associated with a huge progress in terms of survival, and that's a very important point. To avoid any challenge with lines, with implantable chamber, etc., or invasive device. What I suggest is to use systematic checklist. We do that in our RCU for many years now, and we assess this process. And as you can see on this graph, we have a huge decrease of nosocomial infection. You can see the rate of VAP, of ventilator-associated pneumonia, in this study after the implementation of systematic checklist, of an electronic checklist that we use at the bedside, and that can be very efficient to decrease the rate of infection due to not useful device. We don't have to keep a central line if we don't need. We don't have to keep an urinary catheter if we don't need. And that's a process to decrease the exposure to not useful device. So my recommendation number 3 is very simple. Remove the bed sheets. It makes everything so easy to look at your patient. To You can see the knife in the here it's a caricatural situation, but you can see this small skin injury, which can be a purpura, and so that's an emergency, a medical emergency. And this patient needs antibiotics immediately without any daily. So that's very important. Remove the bed sheets and look at your patient. The one of the last things you can do with clinical examination is to assess the severity of sepsis, and that's quite important to gauge the treatment. And for instance, if you look at your patient, you want to know if there is a cardiac failure, an acute cardiac failure, which can happen in a patient with septic shock. There is around 35% as soon as the septic shock starts, would develop a cardiac failure, an acute cardiac failure. And in this patient, you can look at the neck. There is some distended veins. You can look at the lungs. There is some pulmonary crackers. Uh, there is some peripheral edema at the level of extremities, and you can hear the cardiac sound, and there is some very specific sounds uh, suggesting a cardiac failure, and you can do that only with your hand and your stethoscope, and you don't need a lot of materials to do that. That's free. There is no cost, and you can really assess the severity of this patient from this side. Remove the bed sheets, and you can look at the motors in your patient, and there is some very good modeling score which has been proposed by the group of Aïta Aufela in Paris, in France, and you can use this modeling score that is very well associated with survival, and that's a reflect of microcirculation, and without, once again, without any cost, that's free. There is no device to buy. You can assess your patient and know if his or her microcirculation is impaired or not. Other thing is skin temperature. Touch your patient, be in contact with your patient, and if your patient is really cold at the level of extremity, if there is some skin temperature difference between two and core, between two and the room temperature, that's a very good sign of severe infections. So once again, I stress on that. I know it's not fashion, but there is no only screens and computers to take care of our patient. We need to be in contact with our patients. That's very, very important. The last thing in terms of severity, which is really great, that's referring capillary time. There is I know you know the Andromeda shock study performed by the group of uh, Glenn Hernandez from Chile. That's an international study. We are waiting now the Andromeda 2 RCT, and just looking with a very easy process, not expensive process, but that should be very formal, and you need to formalize the way to measure the referring capillary time. Uh, you can look at the microcirculation as a tissue perfusion of your patient. Once again, it is free. You only need a tip of glass, but that's really easy to do. And this almost efficient as lactate is, even perhaps better, but there is no competition between lactate and peripheral perfusion. We need probably both, and we need to integrate both in our reasoning at the bedside. So that's really useful, and that's totally included and in the clinical examination. So use few minutes, few seconds to avoid extra cost. Don't be you can like a lot devices, that's really fun, but don't lose too much money when you can do the thing very easily for free using just clinical examination. So really it's important, and it's important to repeat this uh, on a regular basis, because our patient is moving all the time, and he can improve, but he can also deteriorate his status. So we need to repeat this to know the effect of our treatment. So that's my recommendation number 4: few minutes to avoid extra cost and loss of time. So how can we improve now? How can the classical common clinical examination may improve in 2025? That was the questions. And what I suggest is to use ultrasound as to integrate ultrasound and POCUS at the bedside as part of the clinical examination. So we performed a few years ago this comparative study. There was a group with POCUS, using POCUS at the bedside for acute respiratory or acute circulatory failure of patient hospitalized in wards. And the other day, that was one day every 2 days, the other team did not use ultrasound. So that was not only ultrasound, but that was ultrasound with a 3 hours training and education for all our staff, our emergency we have a kind of rescue team going in the ward for the patient in shock or in respiratory failure. And there was this 3 hours bundle of education explaining what they have to look for with ultrasound, and have to process and being systematic. And the other group did not receive this education. So they were naive from this education, and in the group A, there was ultrasound and the education. And what was our results? Our results that was that the relevance of diagnosis was really improved by the use of ultrasound, and the short training they received before, as compared with the control group, even if we pair the patient, and even after adjustment, the difference was really significant between the two groups. The duration of stay, of hospital stay and ICU stay, was reduced in the ultrasound group. The number of treatments received during the first hours was reduced in the ultrasound group, and the number of of paraclinical examinations and testing was reduced in the ultrasound group. There was a trend toward a reduced mortality, but that did not reach a significant level in the ultrasound group. So, in for us, from our perspective, ultrasound and POCUS is the fifth pillar to bedside physical examination and should be included in the global clinical examination. So my take-home messages: be fast, be specific, be discriminative. Clinical examination should not be forgotten because we have a lot of screen, a lot of computers, and we spend a lot of time with cell phone, with computers, with screens, etc., etc. So clinical examination is the pillar of the diagnosis. Diagnose sepsis, but if you think sepsis, if you pronunciate the word sepsis, you should pronunciate after the cause of of this sepsis. So you need to find the cause, and you need to assess severity. Is it septic shock? It is sepsis? Is there any microcirculation impairment? You have to respond to this question. Avoid extra cost, loss of time, and also loss of empathy, because if you don't go to contact with patient, you are going to lose your empathy for your patient. We are all physicians, we are all intensivists, because we want to make our patients better. We want to improve the patient status. We want to fight the disease. And being only behind the screen, we are going to lose our empathy for our patient, and thus our motivation for our job. Be systematic. Be systematic. Use checklists. Use process. Be systematic. Be efficient. Don't lose time. Don't lose time with details which are not useful. Be efficient. Your clinical examination should result on a diagnosis and on a way to manage your patient. And try to be naive. Don't be in a kind of tunneling because your patient should have a lung infection. No, perhaps it's just a surgical site infection. If I speak with my surgeons, all their patients have lung infection, and in fact, in 80% of cases, it's surgical site infection. So don't be naive. Don't be naive. Okay, don't be naive, but be systematic, efficient, and naive in terms of forgot everything, and each patient in you, and you should start at zero. And finally, I really think that today, ultrasound is part of clinical examination, and all ultrasounds, and even if I go further, even machine learning, artificial intelligence should be included to help clinical examination and not to compete with clinical examination. So I thank you for your attention. I hope my presentation responded to your expectations, and I'm here to respond to your questions if any you have. Thank you for your attention.
Thank you, Professor Leon, sir. That was really nice, and I think it's very useful for the young students and the young intensivists. Really nice, emphasizing the key aspects of examination and history taking in sepsis. So, may I request you to close the share screen, sir? Yeah. Yeah, thank you, sir. So I request the audience, if they have any questions, please type the questions. Maybe, sir, I can just put up some questions on sepsis as such, more on examination. So, sir, one of the fundamental things which is described, especially in the books, is that a sepsis patient presents with warm and bounding pulses. So, is this correct always, or there are exceptions to this? What is your comment on this?
Could you repeat, please?
Sir, it is mentioned in the literature in most of the books when they talk about examination of sepsis that the patient presents classically with warm and bounding pulses.
Yes, I think that's still true. I guess there is no change in the clinical presentation uh, since the onset of medical world. So I agree with this, and I think it's important to consider this to diagnose or to identify sepsis at the bedside. Yeah.
Sir, but is it true that all patients have, or there are some patients who may not have warm and bounding pulses in sepsis, septic shock, or sepsis presentation?
Or you can have a diversity of presentation. You can have a diversity of presentation. Not sure all patients will present like this, but that can occur, and if the sign is present, that's a good sign of sepsis. But if the sign is not is absent, you cannot exclude the sepsis. Okay.
Thank you, sir. Then, sir, about viral sepsis, sepsis classically is bacterial, like you showed also from urine or for lungs, abdomen, catheters, soft tissue, but a certain amount is viral sepsis, and
Hmm?
which is difficult to diagnose. So,
Yeah.
how can we kind of think of viral sepsis from the history examination or the laboratory tests?
That's a difficult question. First, first we should look at our patient depending on the epidemiology. That's very important. Uh, in your in the epidemiology of sepsis, for example, uh, 90% of sepsis are due to bacteria. So when I look at the patient, my first recommendation is think about that. Bacteria is present in 90% of cases. During the pandemics, for example, virus, COVID or SARS-CoV was the first was most frequent, and you should all the time think in terms of epidemiology. What is more frequent, and what is more frequent in my ecology, in my environment. Uh, when it is viral, is much more difficult. Probably it's much more diffuse, but perhaps this is kind of diffuse infection, lack of precise source of infection, which can be not identified in this case, which should get toward viral infection instead of bacterial infection. But that's really difficult. Hopefully now we have some PCR tests which can help. Uh, but I would say that first think about bacteria because that's I don't know in India, but where our work is really much more prevalent. Uh, if there is nothing in terms of bacteria, and there is a kind of diffuse uh, diffuse infection without a specific organ involved with kind of history in the family or in the community of pharyngeal infection, something like this, I can think about virus.
Thank you, sir, for the answer. So then moving on to shock as such. So septic shock is one presentation of septic sepsis, right? It may be sepsis or it may be septic shock. But when the patient comes with shock, he does not have septic shock written on him. Shock could be cardiogenic or hemorrhagic. So how can we at the bedside, when we examine the patient, think of septic shock rather than a cardiogenic shock or a hemorrhagic shock? Any clues we can pick up?
It's difficult, but one of the characteristic, one of the features of septic shock is to be classically, and it's not true for all patients, but classically is a shock, is a hyperdynamic shock, which means that's a shock with a high cardiac output. So you can use ultrasound, and I think that's in the first hour that's very useful to have ultrasound to look at the cardiac function, and there is no lot of etiology for shock with an hyperdynamic status. That's anaphylactic shock, but there is context or septic shock basically. So that's a clue to all the if there is a bleeding, there is a decrease in cardiac output. If there is a cardiogenic shock, there is a decrease in cardiac output. So that's really the difference between those shocks. After you have to look for bleeding all the time, and especially a digestive bleeding, which is difficult to diagnose. And there is a lot of things in the history in the that can help for this diagnosis, and that's difficult at the bedside, at least in the first hours, to discriminate a septic shock with a cardiac component of with a cardiac failure due to the septic shock, or a cardiogenic shock in a patient with a little bit fever or sometimes a lung infection, which can precipitate a cardiogenic shock. So in 70%, 80% of patients, if you use ultrasound or anything else as monitoring, you can discriminate based on the increased cardiac output. If you don't have ultrasound, but you have a central line, you can use SVO2. If SVO2 is elevated, it's not a bleeding, it's not a cardiogenic shock, for sure. And most of time, it's the increase in SVO2 is a surrogate for an hyperdynamic shock and thus a septic shock. So that's my clues to discriminate these different shock. I hope that can be helpful for you.
Yeah. Thank you, sir, for the answer. So I know this is not really the topic, sir, because it was on history and examination. But if you can tell us a little about the adjuvant therapies in sepsis, like IVIGM or hemoadsorption or bacteriophage. Would you just like to comment on that?
Yeah, I can. But perhaps I'm going to disappoint those who believe in this treatment. IVIG, there is a lot of studies on, and lot of and uh, significant number of studies being positive for IVIG, of RCT being positive for IVIG, even if there are a lot of different immunoglobulins, so that's quite tricky. But I think that's in the future, that can be a very interesting treatment, and that makes sense to have this treatment and to help the patient with that. Today, I'm not sure there is, we don't use, and I'm not sure that there is a good indication uh, in routine at the bedside. But I really think we should consider this treatment as a possible treatment in the future. Uh, for hemoabsorption, are really more embarrassed because there is a lot of debate about that. Uh, I come from the school of Richard Hotchkiss in St. Louis. In the US, I work a lot with Professor Hotchkiss, who is an intensivist and an immunologist, and I don't believe that removing cytokine can help. I think that cytokine are leaking in a large subset of patients with septic shock, even if some in another subset there is too much. Uh, I think that there is some very interesting point with absorption of LPS, but that works only in patients with gram-negative bacteria at the onset, perhaps in very few models. Uh, and basically, I heard lot of experts in symposium talking about the benefit of hemoabsorption. Lot of experts in symposium. Uh, okay, but I never read a positive study on that, a positive high-level study on the use of hemoabsorption, which is quite expensive, quite difficult. I don't like a lot all invasive process, especially in these patients which are at risk of infection from anywhere. Uh, so so uh, I know that there is. I have some friends, so they are really believer of this technology. I know a lot of very good experts and very respected experts who believe in hemoabsorption. Uh, I'm not keen of this procedure, and in the literature, I never read a good RCT which was positive using hemoabsorption. The literature is zero. There is only expert telling that it's very good for your patient. It's very good for the industry probably also. But if there is some data and if that can save life, I would use immediately. No way. But to date, I don't know. I never read any good paper on that. The third, sorry,
The bacteriophage.
bacteriophage. That's very interesting. The process is very interesting because that can save antibiotics and there is no resistance to bacteriophages. I think that they use a lot that in the east countries of Europe. Uh, in France, there is a, randomized controlled trials which has been supported by the French Ministry of Health, and we are waiting for the results. The principle is really attractive uh, as I am PhD in infectious disease. So in terms of infectious disease, that's fascinating. I like the principle, but once again, we need some good studies and we need some positive studies to use it at the bedside in our patient in routine because for me, to date, there is no good data to do that at the bedside, even if I like and the principle and I like the way to think about to rethink about bacteriology using bacteriophages.
Thank you, sir. Just a final question, sir. So you mentioned about the use of POCUS, and
Yeah.
it is definitely being widely used and coming up in all the areas, not only sepsis. But my question, you mentioned one study also, sir. So my only question is, sir, is there a large meta-analysis or a large study showing whether POCUS is how helpful or whether it's really helpful when it's used in sepsis patients? We have small studies. You also showed one study, but is there a large meta-analysis or a large study showing how effective it is or whether it is really effective in septic shock patients or sepsis patients?
I think that's now there is some meta-analysis. I don't have this in mind, specific meta-analysis, but I think that there is some. I know that there is some meta-analysis showing the benefit of focus in trauma. There is a benefit of sepsis in critically ill patients. Uh, I don't have in mind a specific paper in sepsis. Uh, I don't have in mind such paper, but I'm pretty sure that there is some very good RCT showing that the use of ultrasound uh, can not probably change the mortality, but can improve the way to manage this patient. I don't have a specific paper in mind right now, but there is a lot of literature with POCUS now, and the level of evidence is quite good. There is a cost of the machine, of course, of the device, but it's not really expensive. It is reusable, so you can use your machine with lot of patients, and that's quite efficient. So I don't have any conflict of interest with the industry on POCUS, because I'm not an expert in that, but really that's helpful for the first hours, and that's now in the recommendations of sepsis and in the surviving sepsis campaign.
So just your personal opinion. You see, sir, as we are going on, the art of history taking and examination is dying out. And if we were to focus and teach our young people more of history and examination, we would not need focus. And focus is coming in because students and young people are not taking the history and not examining the patient. Do you think this is what I'm saying is correct? I mean, this is just your personal opinion.
Yes, uh, I respect this opinion first. I respect every opinion. Uh, but if I can, I don't fully agree. I really think that focus may help. That was a study I show you. That was a group of there was in each group of a rescue team, there is one junior and one senior physicians, and most of them are very good, and really that's really helpful to look at the earth function, at the lung function, and gave you some specific response in only a few seconds. Uh, Probably better, even if I yeah, I support the clinical examination. You cannot say the
I,
other
I
thing,
am from, I
but
am I am from the old school, sir. I believe more on history and examination.
no, but I am also from the old school, because I'm not younger, unfortunately. But today, when I'm on duty in the unit, I use not I use a lot focus at the admission time. After we have some other device, some monitoring that can help. After I can use cardiac ultrasound, but during the first hour, I really think that can help, even if we are from the old school and even if we have our experience with that focus. I think that's really uh, an additional plus to manage these patients.
Yes, yes. Okay, so thank you so much.
Mm.
Yes, definitely some use is there, but anyway. So thank you very much, Professor Leon, sir. Really wonderful
Thank you.
listening to you, answering all the questions, and we had a lovely audience. And I thank the audience as well for their patient hearing. Thank you very much, sir. Goodbye, sir.
Thank you. Thank you for the opportunity to speak with you.
Bye bye, sir. Good night.
Bye bye.